Hello and welcome to our show, To Your Health. I'm Szymanski, the Interim CEO and President of Marlborough Hospital, and I'm so pleased to be taping our very first show from our new Cancer Pavilion. And in the very near future, you'll hear lots of information about the building and some community events that are planned around our opening. So today, though, we're going to start focusing on various forms of cancer and the types of providers that you're likely to meet depending on the reason that you've chosen to have your care done at Marlborough Hospital and at the new Cancer Pavilion. So with that, I am so excited to welcome Dr. Jennifer Davids with us today. Dr. Davids is a colorectal surgeon, and we're going to learn lots about what exactly is a colorectal surgeon, how does somebody get interested in the field. So we're going to spend the next half hour just getting to know Dr. Davids and her practice. So welcome. Thank you so much for joining us.
Thank you.
You are a colorectal surgeon. Now, I know that one does not become a colorectal surgeon overnight. So take us back a bit. Where did you go to med school? First of all, how did you even decide that you wanted to go to medical school?
Right. So I think I probably always was interested in medicine. Anytime I had gone for a doctor's appointment, just routine things, I always was fascinated by how the office worked or how the hospital worked. If I needed to go get an x-ray, I'd always be looking around to see who else was there and how things worked. So I've always been interested in the hospital environment. As I approached the decision to go to medical school while I was in college, I was at Harvard for college, and maybe my second or third year of college, maybe by my junior year, I was always very interested in science, and I was a major in biochemistry. So I had a lot of exposure to a lot of different types of science. I was always very interested in that and knew I wanted to pursue that, but I also wanted a little more of a human component. I knew that I wanted to interact with patients and to be directly involved in patient care, while also having the ability to pursue scientific interests and to try to advance the field.
So any family background in medicine?
Actually, none whatsoever.
Wow, that is really unusual, because most people that I, have this conversation with, a parent or an aunt, uncle, have been in the field, or...
I think probably a third either have a personal experience with medicine, either themselves or their family. Probably a third have family members who are physicians, and a third have neither. Just were interested, and that's probably where I fall.
So you did undergrad work at Harvard, and then medical school?
I was at Yale for medical school.
And how did you make that decision to move? I mean, you could have stayed in New England, in Massachusetts, correct?
Right.
But
there are a lot of options. I think we're really lucky if you're a student or if you live in Massachusetts or in New England as a whole. There's so many excellent medical schools, and you have a lot of exposure to labs, to different types of physicians and to different specialties. In a way, it's almost overwhelming. So I actually, part of the story is linked to my husband. So we were actually dating and then married in medical school. So we both ended up at Yale. So that was a really good opportunity for us to go through this whole process together.
Now, did you grow up in Massachusetts?
I grew up on the North Shore.
Wow.
In Marblehead.
Good. Yeah. So this is coming home in that you went to medical school. But you, because your residency was in New York, correct?
So I started, residency for general surgery, which is what I did before starting my fellowship, is 7 years long. And so my first 3 years were in New York with my husband when he did his internal medicine residency for 3 years. So I was at New York Presbyterian Hospital, which was a great experience.
Absolutely.
It's a really nice opportunity to be part of the city, take care of the city, take care of traumas, people that just walk in off the street, whereas here pretty much everybody either comes by ambulance or is driven. Just see people who, you say, where do you live? Oh, I live down the street. So it was a very different experience, a very different environment, and great training.
So let's talk about the training in general. 7 years, which, is that through fellowship? Or
So
just
that
your
does
surgery?
not include the fellowship.
Oh, I didn't think so. So, based on my experience at UMass for a number of years, there's a 4-year general surgery residency. Now, do you have to do a year of medicine, or?
No, so the standard
Actually, it's 5
general
years.
surgery is 5 years, you're correct. And many people, in my program, I was encouraged to do 2 years of lab research. So what I had done is I did my 3 years of general surgery clinical training, then went out into the lab for 2 years, and then came back and completed my final 2 years.
So what does that mean, out into the lab?
So what it means is you're pretty much freed of clinical obligations. You're not a resident taking care of patients on a regular basis. You fill in here and there, but just small shifts. And then you really delve into the lab. You join a lab. I was at Harvard Medical School with Monica Bertignoli. She was a great mentor of mine, a surgeon and a scientist. And so really what allows you to do is focus in on one question and really try to pursue that without a lot of distractions.
So from a research standpoint, and what was it that you were pursuing?
So I did some research with mice, ultimately with the goal of trying to apply that to humans. But basically I was looking at colorectal cancer and using a model for colorectal cancer in the mouse and trying to figure out whether certain chemotherapeutic agents or chemopreventive agents would have an effect on the mouse, and whether this could eventually be applied to humans.
Now, you know, that type of research takes years, correct? So was it already ongoing research? Did you start it? Were you able to complete it?
Right, so it is tricky, and I think the hardest part when you do decide to make the commitment and spend time in the lab is you need to find a good mentor and you need to find a good lab that has a lot of projects. So the entire lab basically has a timeline that it's just constantly going. Multiple projects come and go and get completed. You need to just join that group, and you know, so it gives you the opportunity to start a fresh project and really get to work on that while at the same time completing other projects that have been started by others, because that work really builds on your prior experience.
So is it grant funded?
Yes, I had a T32 training grant, which is an NIH-based grant. That's
great. Now, and when you're finished your research, do you publish? I mean, is that usually what's expected, that there's a research paper that comes out of the 2 years, or is it still too early?
Right, no, it's expected. I think it's very reasonable that if you start a project and things go well, it's not definite, especially in the basic sciences. You can't promise you're going to have something substantial in the form of a paper. I was able to do that. I was very lucky that I joined a great lab with a great focus and great mentoring that really helped me to do that. But the goal would be that you at least publish one first author paper that is your work.
Now, so you're essentially removed from the clinical arena for 2 years.
Right.
How did you deal with that? Did you, I mean, you said you would fill in here and there, but that's not the same as practicing every day. So how do you balance that?
It is very different. You get used to that life where in the lab you have a little more control over your time and you know where you're going to be at what time. It is a transition going back. We all talked about it. I was in a group of residents that had been in the lab, and we were all coming back to join the clinical workforce again. It's definitely a difficult transition, and in some ways you have to relearn a little bit. I'd say it takes about 2 to 3 months, and after that point you actually, someday you just finish a case and you say, wow, I'm better than I was before. I actually have gotten over the hump, and you feel like you've moved on. And I think that break really allows for you to have some growth and development and put things in perspective. Yeah.
There are a lot of people who start their families during those research years and really, you know, solidify their relationships, because it cannot be easy going through medical school and being married and, you know, juggling all of the lifestyle things that you have to manage.
And probably that's the hardest aspect of all of it. I actually had my daughter while I was in those lab years, so she just turned 4. So that's the hardest part, is managing that, trying to get used to your new world in the lab, having a child, and then most importantly, when you come back, you're a senior resident, you're getting paid 24 hours a day, you're in charge of a team, and you're really leading things while trying to refine your training while having a young baby in the house.
Yeah, that is challenging. And you know, these are grant-funded projects, so I'm assuming the salary is a stipend. It's not enormous.
So actually, while you're in the lab, that's exactly right. So residents are not known to get paid a lot, for sure, to start. And then when you spend the time in the lab, the grant money is less than what you would make as a resident. So what you actually do is moonlighting. So you are integrated into the resident system, and now with the restrictions on work hours for residents, the way most hospitals make up for that is having moonlighters. So the research residents will fill in 1 night a week, 2 nights a week, and then you actually get financially compensated for that.
Which is great.
To supplement your salary.
So, but you can't moonlight as a colorectal surgeon at night.
No.
So what does a surgery resident do from a moonlighting standpoint?
So in general surgery residency, which is when I moonlighted, you just act as a resident, just as exactly what you were doing before you came out.
So you'd see patients in the ED, evaluate them, and then call the surgeon, you know, to make decisions,
Exactly.
that type of thing.
That's mostly nighttime because we were all working in the lab during the day. So then once or twice a week we would go into the hospital, exactly that, see patients in the emergency room, take care of the inpatients on the floor, answer phone calls, and then talk to the team in the morning.
Now, what was night? 7 p.m. to 7 a.m.? And then lab?
Lab is
the next
basically
day,
the next morning.
Yep.
I think a lot of times, just to stay fresh, you take a quick nap in between.
Yeah.
I think that
Yeah.
otherwise the days sort of roll into each other and it feels never ending. So it's nice to take a little bit of a break, wake up, shower, have a cup of coffee, and then start the day.
You know, I think there are so many people who don't realize what you and many other of your colleagues put into your education to be the best, you know, physician that you can be and bring them the best of research and practice. And, you know, I applaud you because it is not easy. With that, we're going to take a short break, and when we come back, we'll talk, we'll move you from your residency world into your fellowship and talk about what you're going to do with your future.
Great.
If you are like most people, your time is precious. Save time by taking advantage of the convenient electronic services that your institution offers. Simplify your financial life. Arrange for the direct deposit of your pay and benefit checks and other regular income. Direct deposit is safer and more convenient than paper checks. There are no delays in getting funds deposited. You might even get a break on your checking account if your paycheck is deposited electronically. You also arrange to make the most of your regular payments, such as your mortgage, health insurance premiums, utility bills, and investments in a mutual fund automatically. This can be an easy, economical alternative to writing and mailing a lot of checks each month. Withdrawing money from the ATM is also an option that can work better instead of standing in line at the branch or rushing to get to the branch during banking hours. Consider using a debit card or check card to pay for purchases from your checking account without writing a check. Banking from home, by phone or computer also can be a time saver. This Money Minute has been brought to you by WMCT-TV and St. Mary's Credit Union.
Hi, and welcome back. I'm Candy Szymanski, and this is To Your Health. Today my guest is Dr. Jennifer Davids. She is a colorectal surgeon, so we've just spent the first 15 minutes getting to know you a little bit better. So now I want to move to, you've done your first 3 years of your surgical residency, taken 2 years off, started a family, gotten married, and now you have a fourth and fifth year to do, and then a fellowship.
Right.
So where did you do that fourth and fifth year?
So I was at Brigham Women's Hospital in Boston, and I think we were talking about earlier about the transition to those years. I think those last 2 years of training are really important, not only in terms of building your leadership skills, running a team, making sure that your communication skills are really good in terms of speaking to the attending surgeons, all the way down the chain of command with the residents, also the nurses, the OR staff.
Absolutely.
But also refining your surgical skills and deciding really what you want to do with the rest of your life.
So, you know, I think that's a great point because you're still doing general surgery at that point. You don't specialize until you complete your residency.
Right.
So you are a general surgeon, meaning that you can, you know, take out an appendix, do, you know, cholecystectomies, remove gallbladders, trauma, all of those things. You've had to do the soup to nuts type thing.
Right.
So why did you choose the Brigham and not stay where you did your first?
So that was actually a personal reason. My husband was trained in internal medicine for 3 years at the same time as I was at New York Hospital. And then for him to complete his fellowship, he interviewed at Dana-Farber and really liked it. And so I came along as part of that so we could stay together.
And what's his specialty?
He's a lymphoma specialist.
Oh my goodness.
So
that's another, you know, very challenging disease to manage. So now you complete your residency, yay, yay, everybody's ready to celebrate, but you're not done.
Right. So many people these days are doing fellowships. I think it just offers a little more of a chance to get some expertise in one area and to really focus in. Whereas we said general surgery, it's a month or two at a time, very different things. A month on vascular surgery, then colorectal surgery, then trauma surgery. So you finish it all, and sometimes many of us just felt like wanted to focus in and only do that for 1 year and get a little sense of continuity.
So the fellowship is 1 year?
Mm-hmm.
And, okay, so you're a bright young woman. How do you pick colorectal surgery out of all of the other things that you could have picked?
That's one of the most commonly asked questions of me.
I bet it is.
And when I decided on colorectal surgery, one of my mentors had said, great choice. The only hard part is that you're going to have to explain yourself at cocktail parties. And that's pretty much where it stands. So it's a hard decision when you've done a little bit of everything. You've been trained to manage such a wide range of conditions. Ultimately, my research interest was in colorectal cancer, and so that led me toward this. Whereas, you know, from a clinical angle, what I really like about colorectal is that I see people that are men, women, young and old, sometimes with cancer and really serious life-threatening conditions, other times with things like hemorrhoids, fissures that are not life-threatening but uncomfortable.
Mm-hmm.
So in a day, I get to see a huge variety of things. I get to do smaller procedures, larger abdominal cases, laparoscopy, colonoscopy, yet at the same time I can be an expert in one part of the digestive tract. So I like that mix from a clinical angle.
So during the break, we were talking about the fact that you appear to be very young. How could you have gone through all of this, you know, all of this education? And but you're not new to colorectal surgery. This is,
right.
You know, yes, you've finished your fellowship, but you have really immersed yourself in these diseases for the last year or so.
Right, and so it's a balance. I do look young, and as I've said to patients, I can't change my appearance, and I can't change my age at this point. You always have to start somewhere. But at the same time, I've had 8 years of training after becoming a physician. Throughout my residency, I did rotations at every level in colorectal surgery, pretty much doing abdominal surgery every day. Colon, rectum was some of the most common things that I did. And then lastly, I chose to do an additional year specializing in this, having been in the OR all day, every day for an entire year.
So let's talk a little bit about board certification. Mm-hmm. So you are board certified as a general surgeon. Mm-hmm. Now, I know that you want to become board certified as a colorectal surgeon. What does that take?
Right, so the process for both, you have to do a written and an oral exam for both the general surgery boards and the colorectal surgery boards. So it's actually 4 exams that you have to take when you finish your training. So while I was in my year of fellowship, I completed my general surgery boards. And then it's the same process again for colorectal. And those happen usually in the spring of your first year of training. So I'll be sitting for those boards later this year.
And we wish you a lot of luck. I mean, like many specialties, you get experience and then you sit for the exams, but right. You have to do both a written as well as sit in front of someone,
right.
And prove to them that
right.
you know your disease and your specialty inside and out. Pardon the pun.
Right.
And so it's not just simply sitting in front of a computer and taking an exam.
Right. That's the first half, and that's actually called the qualifying
right.
exam, that you are qualified to take the real exam.
Then the real exam, that's right.
Which is basically in a hotel room sitting like this with a stranger, but usually somebody who's very well reputed in the field that has a name on the textbook.
So I was going to say, so you've read a lot of their work. And
right, usually an intimidating character, and then you just discuss cases, and ideally what it's really meant to do is just have a one-on-one conversation. I have a patient like this, what do you do? And so the idea is you just explain your line of thinking.
And exactly what you've been doing every day prior to that conversation.
Exactly.
Now, I did read that there are less than 3,000 of you colorectal surgeons. There's a very, very small number of women, so you clearly are a minority in this field.
Right.
But that has to be a wonderful benefit for people in this community who, are just not comfortable going to see, a male surgeon, or at least not the first visit. So do you find that many of your patients are women, or you have a nice balance?
So far it's actually been about a 50-50 mix, which is what some of my male partners have as well. What's nice about colorectal is there are some female-specific conditions, but largely it's conditions that affect men and women. However, with that being said, a lot of women do feel more comfortable seeing a woman. And I'm happy to be that person if that's the case.
I think it's going to be a wonderful benefit. Now, your practice is going to be located in Southborough, and you're going to share your time with, you know, a colleague, correct?
Right. Dr. Kareem Alavi is also out in Southborough. He's been there for a couple of years.
He has.
And so we've actually staggered our schedule so that one of us will be there pretty much every day.
Now, your fellowship was here at UMass, so you got to know Dr. Alavi over the last year, and
Right.
I hear that you guys are a very solid team.
There's actually 5 of us in total. Half of my time is at UMass at the Memorial campus, and then half of my clinical time will be out in Southborough. So there's a whole team of 5 of us that work together. And so we're always able to bounce, you know, ideas and cases off.
That's
call
great.
Coverage.
Great.
So
in the practice, Dr. Makel, is that correct?
Dr. Makel, yes.
Makel, yourself, Dr. Alavi.
Dr. Sweeney and Dr. Sturrock.
Great. Wow, that is a great team. That's
Yeah.
a great team. Now, in Southborough, let's talk about, you know, first of all, how would I get to see you? Do I need a referral?
Right. It depends on your insurance. Usually you don't. Usually you can just call our office and they can give you all that information depending on your insurance.
And, you know, I was reading your background, and I certainly want to have you back to talk about some very specific diseases. But you said, you know, anything from a fissure, which is a little tear in your rectum, to, you know, life-threatening colon cancers. Some of those diseases, like colitis, diverticulitis, I think of being treated more medically than surgically in the beginning. Do you get involved in the very beginning of that type of treatment, so you have to dabble in medicine as well as surgery?
Right. So it is definitely a team approach, and we interact very closely with our medicine colleagues and gastroenterologists on pretty much all of these disease processes. So a lot of these represent spectrums where certain people just can be managed medically. Sometimes things present very acutely where a surgeon is needed as an emergency. And there's a whole gray zone in between where somebody is having multiple attacks of diverticulitis and ultimately would benefit from a colectomy. And, you know, so we're constantly seeing patients that have been referred to us from GI or internal medicine, and then often referring them back for various things.
And then you get to establish a relationship with patients, because these are really chronic diseases as well. You know, certainly, you know, the fissures and some of those things are, you know, you correct them, the patient does very well, and you may not see them again.
Right.
But a lot of these diseases tend to be chronic. So
Right.
how do you, is that harder from a surgeon's standpoint to, you know, follow patients over time?
Right. I think it's really gratifying. It is nice to have a combination where some people you're able to say, you had this acute condition, we've treated it, call me if you ever need me, but I think, you know, we're pretty much set. Whereas with other things, you establish big, you know, more long-lasting relationships with cancer patients that have to come back for surveillance. So it's really nice to see people 2, 3, 4, 5 years out and beyond.
So depending on your insurance, you may or may not need a referral.
Right.
But, you know, I would say 9 times out of 10, your primary care doctor will say, you know, this is an issue that I really want to refer you to a surgeon to see, that type of thing. So the benefit for this community, though, is now we have this expertise in Southborough.
Right.
Some of these procedures, surgical procedures, might even be able to be performed here at Marlborough.
Right.
Certainly some of the larger ones, that's not that's not the things that we specialize in. So what type of surgeries do you see yourself perhaps doing here?
Sure. So to start, initially, we're going to do mainly the types of things you would do as day surgery, so hemorrhoid surgery, surgery for fissures, fistula or abscess surgery. So things where you come in that same day, procedure's done, and then you go home later in the day.
Now, as you become more comfortable, do you see us being able to do some, you know, straightforward colectomies, you know, where maybe there's not a colostomy, maybe there is, as we move forward and you get comfortable with the team here?
Right. I think there's a lot of opportunity for expansion and development of that.
And we have added a nurse practitioner that to support your team.
Right.
Because I know it's hard when you service, you know, a number of organizations to be there the next morning to round, to discharge. And so by, you know, adding a mid-level provider to your team, that's really an extension of what you guys do.
Right. I think that's really critical to making it work. Once we build our practice more here, we will be able to have one of us be here to round and see the patients, but then to have someone on site that can provide urgent care and really assess patients on a minute-to-minute basis. I think that's really important.
But as we're down to the last minute or so of our program, I would you know, never complete a program with a colorectal surgeon without talking about some preventive things that we can do around colorectal disease.
Sure.
In a minute or so, what would you say to people?
Sure. So I think it's really important for a lot of things. We pretty much recommend increasing dietary fiber whenever possible. Even for people that eat a lot of salads and high fiber fruits and vegetables, we all know it's a busy life and we miss those things more often than we're able to do it. So I definitely would recommend pretty much anybody to take dietary fiber, either Metamucil, Citracil, or Consul every morning. Take it with orange juice and move on with the day. That way you've pretty much caught up from the beginning. That can help a lot of other conditions like hemorrhoids, fissures, basically regulating the stool and preventing a lot of diarrhea or a lot of straining can help take the pressure off a lot of those conditions.
Absolutely, and certainly as the older we get, the less our body likes to you know, tolerate some of that kind of straining. So,
right. And then equally important is colonoscopy. That's the most important thing.
There has to be a screening piece in there
Absolutely,
somewhere.
to stick to the screening guidelines. Everybody, when they turn 50, or if you have a strong family history, should look into getting colonoscopy at 40 or even potentially earlier. So definitely ask your primary care doctor.
Now, do you do the screening colonoscopies, or are yours predominantly diagnostic?
So it depends. You know, we share this patient load with GI as well. So the gastroenterologists overall are doing the majority of them. We do some as well, and then we also do them on our own patients that we've been following.
Great. Well, you know, just in our time together, you're going to be so successful. And I personally am very thrilled to welcome you to Marlborough and to the medical staff here and to the hospital. You're in a beautiful new setting in Southborough that I think you'll really enjoy being there. Hopefully you've picked up some information about colorectal surgery and what that means, how to be referred. And as I said, Dr. Davids will be, have you started in Southborough?
I have.
Ooh,
I have.
Great. Great. And I saw one patient on the OR schedule here. So she is definitely here and ready to practice. So you can certainly call Marlborough Hospital for some additional information, as well as go online to Marlborough Hospital or UMass Memorial for information on how to get in touch with Dr. Davids. And with that, we thank you very much.